Right, thank you very much. So first and foremost, I'd like to thank Asper and the Corpal team for inviting me to speak, and I'll start off with an apology. When you used to have your regular annual meetings in London, I used to be able to get there. And now that you've come locally to where I live, I've been really struggling, so I do apologise. And it may be because you're travelling to a distance, you put more effort into sort of making sure it's timed out in your diary, etc. Whereas if it's close to home, you always try and pack in even more stuff. So I do apologise. So I was given a remit to talk about infantile spasms and epilepsy, but I was thinking that it would be important to do an introduction about corpus callosum abnormalities first, but Rhonda's done all that work for me now. Okay, so this is going to be a quick revision session of your first talk, followed by epilepsy. So, first of all, the images and photo and the videos that I'm using are all sort of from Google searches, etc., so it's all out there already. Now, what we often recognise is that corpus callosum abnormalities are extremely varied. Okay, and has already been alluded to, the presentation of children, young people and adults with corpus callosum abnormalities is also very varied. And that's obviously going to have a massive impact on what types of symptoms you have. And epilepsy is obviously a symptom of what's happening in the brain. So if the brain abnormalities are different, your epilepsy presentation, if you're going to develop epilepsy, can also be very different. And as already been mentioned, the problems with the corpus callosum, we believe, arise basically antenatally, okay, and very early on, so within the first trimester. And the causes for those can be massive, and also the impact on the development of the corpus callosum can be very different. As already been mentioned, you can have partial or complete dysgenesis or agenesis, but you can also have lots of variations about how the corpus callosum looks. And I do a lot of antenatal counselling for the West Midlands region, and corpus callosum abnormalities is one of the most common conditions that we're asked to advise mothers to be about and the fathers to be about. And one of the most important factors that I'm looking at prior to sort of providing counselling is actually whether the corpus callosum abnormality that's being seen, often with the colpocephaly, the dilatation of the lateral ventricles, is isolated, or if there are other brain abnormalities or other problems that have been found in the baby, such as renal abnormalities. And what we generally feel is that if it's an isolated finding, so there's no other brain abnormalities, then the outlook is generally going to be better. Whereas if there are other abnormalities within the brain, then the outlook is probably going to be worse. Okay? And that's because we feel that if there are lots of other abnormalities, then it's most likely to have a genetic or a syndromic manifestation. And obviously syndromes and genetics play a lot more role in how your brain develops further on, and therefore the problems are more likely to be more significant. So the types of things that we're looking for when we're talking about other brain abnormalities includes sort of the arachnoid cyst, okay, like there. And that's basically a fluid collection within the brain, which is not the same fluid connection that we have in our normal brains, like the lateral ventricles. What we're also looking for, this is an extreme, you can see on mouse, you can't anyway. This is an extreme variation, but what you can see within the brain, this is a slice going that way, okay, and we're looking from the top. Okay, the eyes will be at the front, and this is obviously the back of the brain here. And you can sort of see that the outside of the brain, the cortex, is a different colour to the middle of the brain. Okay, so in this section, the cortex is looking brighter than the middle of the brain, which is looking darker. Okay, and you can also see, though, in this particular brain, is that there's the cyst in the middle, okay, which is showing up as bright white. Okay, but there's also whiteness adjacent to that in the midline on both sides, and that's what we call basically grey matter heterotopia. Okay, so basically those are cells, nerve cells, which should have really migrated outwards to the cortex of the brain, which consists of grey cells, but in fact during development just got stuck in the middle. Okay, And what we know is that if you have abnormalities like that, like grey matter heterosopy, you're more likely to have developmental problems and you're more likely to have epilepsy. And we've already talked about the characteristics of agenesis of corpus callosum. Okay, so you have delayed motor development, you can have balance coordination difficulties, you have problems with bimanual tasks, there may be issues with the growth of your head, so it may be too large or too small, and you may have problems with muscle tone, learning difficulties. We've already talked about the social awkwardness that's often there. You may have problems with how you perceive vision, so depth perception. You can have the pain issues that's already been touched upon, sleeping problems, okay, and epilepsy. But for a good proportion of people, you may actually be asymptomatic. You may not actually have any noticeable difficulties apart from possibly some social awkwardness which becomes more apparent and some clumsiness which becomes more apparent as you get older. So what I'm trying to get across again is that problems with the corpus callosum are extremely varied, okay? No two people are completely the same, okay? We've all got our own unique personalities and unique problems. But unfortunately, some people with corpus callosum abnormalities can actually have a very severe neurodisability, okay? And you may have heard about a genetic condition or a presumed genetic condition called Aicardi syndrome, okay? Thankfully it's rare, and originally it was characterized by having partial or complete absence of the corpus callosum, having very difficult to treat epilepsy, so much so that you don't get on top of it. And there are other features such as you get punched out lesions in the retina of the back of the eye, which we call retinal lacunae, and that's what this photograph at the bottom is. It's the back of the eye. You can see it looks a bit like cobblestoning. So instead of being a smooth thing, you've got basic punched out holes. So with regards to Aicardi syndrome, there are some characteristic facial features. So you may get asymmetry on both sides. None of us have symmetrical faces, okay, but with Aicardi syndrome, that asymmetry is much more noticeable. Small eyes, you can get cataracts, you get punched out lesions in the iris as well, collobomas. You can have cleft lips and palate. The short philtrum is a gap between the nose and the upper lip, and that becomes a bit smaller. And there's other things like the nose is slightly turned up at the nasal tip, etc. And what we also know with Aicardi syndrome is that in addition to the agenesis of the corpus callosum, there are often other brain abnormalities which again sort of suggest that you're more likely to have a difficult or more problematic outlook in the long term. Small head, and because of the small brain, you then have reduced tone. You can also get stiffness in the limbs. Severe global developmental delay, or we should actually say more properly global developmental impairment. And you can have seizures, and these children will often present with infantile spasms, which I'm going to touch upon as well. So again, what I'm just trying to get across is that from the mild symptoms, or probably very few symptoms that you could recognise with corpus callosum abnormalities, to the extreme, okay, where there's just lots of difficulties. So that's just important to recognise that variety, that heterogeneity. Now, Aicardi syndrome primarily affects girls. In boys, it's felt to be lethal, so often results in a spontaneous miscarriage. Previously, we felt it was due to an issue with the X chromosome. So girls have 2 X chromosomes, boys have 1, and therefore, in girls, if it was an X chromosome issue, you've got 1 potentially good X chromosome, which helps to keep you alive and help you to survive. Whereas with boys, if you have a significant issue with the X chromosome, that might be just too much. Now, research has basically said that with Aicardi syndrome, there seems to be a variety of phenotypes, a variety of manifestations. So people with Aicardi syndrome can be very varied too, okay? And the general feeling, therefore, is that it's not one genetic problem. There could be a group of genetic problems that can present with this presentation. So again, corpus callosum abnormalities is not the same for everyone. It can be extremely different. Again, the outlooks can be extremely different. And the things that they need with regards to treatment and support can be very different. So we have to think about individualized care, and I don't like sort of trying to group people that this is what you've got, so this is what you must have. It's important that we assess each child individually and try and manage the problems that that child has. So moving on to epilepsy. So I do a lot of medical student teaching, so I've got a tendency to ask the students, okay, so I'll say, give me a diagnosis of epilepsy. Does anyone want to put their hand up and tell me what epilepsy is?
Electrical activity that gets drummed up somewhere.
Yeah. That's right, that's good. Okay? So there's basically 2 or 3 main components of epilepsy. Okay, so first of all, it arises from the neuronal cells within the brain, and it's due to basically abnormal electrical activity arising from that. But the main thing about epilepsy is that, yes, that's the cause, but how does it manifest? Okay, so what does epilepsy do for that person? Okay, so as has just been demonstrated, what generally happens is motor abnormalities. So everyone recognises that with epilepsy you can have stiffening and you can have jerking. Okay, those are motor abnormalities. But epilepsy again is extremely variable. You know, so some people may have sensory disturbance. So they may just get some numbness or some paresthesia, some tingling. Okay, nothing more. Some people may have a change in their emotions, might feel frightened as part of their seizures. And some people may have issues with their behaviour, so they just become ratty during that time or become very subdued and very quiet during that time. And many people have a combination of lots of things. Okay? So again, epilepsy is not a single thing, it's a whole spectrum of things. So that's why we often refer to not epilepsy, but the epilepsies. And when it comes to managing a child, young person, or an adult who develops epilepsy, you're going to have to basically see lots of healthcare professionals, okay? And that basically means that you'll be seeing, for instance, a neurologist or a physician who's basically going to think about, could this be epilepsy? And if they think there is a chance that this is epilepsy from the history that you're giving, or from video recordings that you've got, we'll then refer you on to other specialists to get tests done. So you'll see a neurophysiologist who will do your EEG, or a neuroscientist who will do your EEG, which is looking at the electrical brain waves. We'll refer you, for instance, for an MRI scan to see what your brain looks like, to see if we can find a structural cause for the epilepsy. And you'll probably be under the care of a general health physician as well. Okay, so again, epilepsies and diagnosing and managing epilepsies is not down to a single health professional. You need that multidisciplinary team approach. Okay, and irrespective of whether you've got a formal diagnosis of epilepsy or not, if you're having unusual movements or unusual behaviours, we need to get a wider team involved, and that would include, for instance, school and education. Okay, and we need to get them on board, and you'll find out that a lot of your children will have individual healthcare plans, or hopefully an education, health and care plan. Okay, but those are actually very difficult to get hold of. It's often a fight for you and those who get EHCPs. So when you watch television programs like Holby City or ER or whatever, you'll always have actors playing characters in there having seizures, and what you'll be seeing is a generalized tonic-clonic seizure. Okay, so everyone seems to recognize what a generalized tonic-clonic seizure is. You basically have stiffening, which is a tonic phase, followed by rhythmical jerking, which is the clonic phase. Okay, associated with loss of consciousness, often associated with difficulties in breathing, often associated with drooling, gritting teeth and grinding teeth, maybe associated with incontinence of urine or incontinence of feces, and eventually the jerking will gradually come to a halt, and you go into a post-ictal phase where the person's unresponsive, seems to be in a deep sleep, often pale or blue around the lips, not responsive at all, and therefore you start thinking that things have gone wrong in a big way. But eventually they seem to wake up, and that may take half an hour to an hour. Okay? And that is just because the amount of energy that's been used during the seizure itself has been massive, and therefore they just need time for those energy reserves to come back and basically wake up. So we've talked about epilepsy. So epilepsy starts with abnormal electrical activity, often at the surface of the brain where the nerve cells are. Okay? Often it is basically accentuated, so increased electrical activity, and then that basically causes your brain not to work properly, causes your body not to work properly. Okay? So what this, yeah. So what I'm trying to get from these is that you may actually have parts of the brain, not the whole brain, but parts of the brain which are causing electrical activity. And that might be due to structural abnormalities, that part of the brain is just not formed properly, or it may be due to scarring and injury that's happened to that part of the brain. Or sometimes it may be just due to some networking issue that's causing it that we can't see on an image, on a scan. All right? So if you have a single part of the brain, or maybe a couple of parts of the brain, but one hemisphere, then you may develop what we call focal epilepsy. Okay? And focal epileptic seizures are generally more subtle, and they may consist of sort of being a bit confused, or it may be that you have those sensory problems, or you may just have some jerking involving one side. All right. But some people will also have what we call generalized epilepsy. And with generalized epilepsy, what that basically means is that you're having abnormal discharge affecting both sides of the brain simultaneously. And if you have generalized epilepsy, that usually causes impairment of conscious level to a significant extent. And then you usually have features which affect both sides of your body. All right. And then some people have a combination of both. Okay, so you may know from yourselves, or you may know from your children, that you know that something's not quite right with them, maybe a few minutes in advance because of how they're behaving, for instance, or they're saying that they got a funny taste in their mouth, or they've got tummy ache or something like that. And then they basically have a big seizure where they lose consciousness, okay? And what's actually happening in those situations is that their epilepsy is starting off as a focal epilepsy. So they're basically having some abnormal activity involving one part of the brain hemisphere, okay? And that's probably then what leads to what we call a focal sensory seizure. So basically, they started off with that seizure activity in one part of the brain. That's then causing the funny taste or the funny smell or the tummy ache. But then what's happening is that activity is not just staying confined to one part of the brain, it's then spreading to involve both hemispheres. And that's why that seizure then becomes what we call a secondary generalized seizure. So even though it starts off in one part of the brain, the activity then spreads to involve the whole brain, which then basically causes a generalized epilepsy. Now, with regards to the focal epileptic seizures, depending on which part of the brain the abnormal activity is, that's going to then determine what the manifestation of the seizure is going to be. All right? So Rhonda put up a lovely picture beforehand, okay? I think it's from Queensland University, wasn't it? Where basically it was talking about which part of the brain causes what types of, what part of the brain has what functions, okay? So this is basically similar, but it's just basically saying that if your abnormal activity, for instance, arises in the frontal lobe is where our motor cortex is, okay? So that's the part of the brain that controls your movements. So if you have basically a frontal lobe seizure, you're more likely to get motor manifestations, okay, like stiffening or jerking. The parietal lobe is our sensory cortex. So parietal lobe seizures often present with those pins and needles, that numbness, okay, things not feeling the same. What was also alluded to earlier was that the occipital lobe is our visual cortex. So even though it's the furthest part of the brain away from the eyes, that does the vision aspect, okay? And occipital lobe seizures will often therefore present with visual problems, but these are usually crude visual problems. So what you'll basically have are patterns, or you'll have flashes of lights, okay, that you'll see as part of your seizure. Now, one of the most important, I mean the whole brain's important, but one of the most important complex areas of the brain is the temporal lobe. The temporal lobe has lots of communications with the other lobes of the brain, and therefore, when you have temporal lobe seizures, the manifestations are actually quite complex. So with temporal lobe epilepsy, children and adults will often feel scared. Okay, so feeling frightened is often from a temporal lobe seizure. You may have visual hallucinations, but those visual hallucinations are often more well-formed. So they might see people, they might see insects, they might see monsters. Okay. You also get auditory hallucinations. Okay, and that may include, in some circumstances, voices, but more often it's just sort of noises that you can hear. And it can affect things like memory. Okay, so again, you can hopefully understand why epilepsy is also very varied. Okay? So when you talk about epilepsy about one person, it's probably going to be very different to epilepsy for the second person. So, generalized seizures, I've already said, generalized seizures involve basically abnormal electrical activity involving the whole brain, so both hemispheres. And there are many different types of generalized seizures as well. So absences, so that's space becoming vacant, sometimes with fluttering of eyelids, lip smacking type movements, maybe subtle movements of the fingers, maybe some head nodding, and then you come back after a few seconds. Absent seizures usually occur many times a day, okay, and usually last maybe up to a minute at most. Myoclonic seizures is sudden muscle twitch. A spasm is basically a muscle contraction, but followed by a delayed relaxation. So you go into contraction, and then you basically slowly relax. Clonic is rhythmical jerking. Tonic is just basically a prolonged period of stiffening. Tonic-clonic is a stiffening phase, followed by the rhythmical jerking. And atonic basically means just loss of tone. So for no reason, well, for a reason, but suddenly you basically lose all that tone. And often these are the people who with epilepsy often have drops to the floor on a frequent basis. And they're the ones who wear the epilepsy helmets, like the martial arts helmets, to protect the head and face from injuries when they keep falling. So, this is obviously a neonatal baby, okay? And what we're seeing here are basically the clonic seizures. So you can see there's rhythmical jerking, mainly of that left arm and that left leg. So when we see, obviously, babies twitching, we don't like that and we get twitched, okay? So we have to try and investigate. So the next step that you'll be doing is basically getting an EEG done, okay, to try and find out which part of the brain is affected. First, and also to confirm that this is an epileptic seizure and no other type of movement disorder. And then hopefully get the right treatment on board to get control. Okay, so this is an epileptic spasm. And just pause that. So, that's not going to play yet, good. So we'll just talk about epileptic spasms before I show you this next video. So epileptic spasms or infantile spasms, people used to call them salam attacks, okay? So what used to happen with these practically is that these children, babies, and that's why infantile comes in, will have sudden contractions and flexion movements, often of the arms and legs and the head. So the head comes down, the arms comes out, and the legs come up. And these happen in clusters. So you basically just don't have a single episode and stop. They basically keep on clustering. They're very distressing, so these babies will often start crying. And we don't like that type of epilepsy, okay? Because epileptic spasms or infantile spasms are a form of what we call a developmental epileptic encephalopathy. And that basically means that this type of epilepsy is a symptom of something else going on in the brain, and that the outlook for these children, because of these seizures, but also because of the underlying problem that's causing the seizures, are likely to have significant developmental problems which become more apparent as they grow older. And also with developmental epileptic encephalopathies such as infantile spasms, they are generally harder to control with anti-seizure medication. Okay. The other thing that we know about epileptic encephalopathies, and especially infantile spasms, is that often there is a delayed presentation and delayed diagnosis. And when I say delayed presentation, parents are usually very concerned early on, but being listened to and people then recognising that this is epilepsy takes some time. So the healthcare professionals can be a little bit slow in diagnosing infantile spasms. And often these children are diagnosed as having things like colic or reflux. Okay, or these are normal baby movements, and parents are falsely reassured by health professionals. And then it becomes more apparent that these episodes are happening more frequently and are more problematic, and then eventually a diagnosis is made. Now, our general feeling is that the earlier you make a diagnosis of infantile spasms and the earlier you start treating, the better the outlook is from a developmental perspective for that child. So really, we do need to try and make sure we listen to parents better, okay, and diagnose this epilepsy sooner rather than later. So what I will do is I'm just going to show you this video, hopefully it'll play, from Infantile Spasm Trust. Okay, so I think this is a nice selection of videos, because the other thing is that it also tells you or shows you that the seizures can actually be quite subtle. Okay, so it's not the typical infantile spasm. Often it might be a sort of shoulder shrug or a head drop or the eye suddenly going up. So again, the presentation can be varied. And often children who already have developmental issues, like low tone, etc., the infantile spasm may actually be more subtle and therefore more likely to be missed. Okay? So what's important is that if you as parents or carers have concerns about your baby, take some video recordings. Okay? I shouldn't just say baby, any of your child that there may be unusual episodes they're having. Take video recordings, show your GP, okay? And basically, if you're still concerned, just insist that you get referred to the right person, the pediatrician or the pediatric neurologist. And with regards to infantile spasms, the treatments of choice is a combination of vigabatrin, which is a typical anti-seizure medication, but also steroids. Okay, so studies like the United Kingdom Infantile Spasm Study and the International Collaborative Infantile Spasm Study have shown that a combination of steroids and vigabatrin for most of the children with infantile spasms is generally more efficacious in controlling the seizures. Now, the issue about infantile spasms is that you have to look for an underlying cause, because for the vast majority there is an underlying cause, okay? And it may be a structural brain abnormality, it may be with corpus callosum abnormalities, it may be due to brain injury because of birth injury, for instance, but it may also be due to an underlying genetic condition, such as inherited metabolic condition. And what we know is that if you can find an underlying cause for the infantile spasms, then unfortunately, the long-term outcome for that child is probably going to be worse than if you can't find a cause. Okay, but it's important that we make the diagnosis as soon as possible and start the treatment as soon as possible. Okay, so this is just basically saying that if you've got any concerns and we think that they're in keeping, that the episodes are in keeping with epilepsy, it's important to do an EEG to see if that gives us any additional evidence or information about the epilepsy. Now, with corpus callosum, with infantile spasms, the EEG is just extremely chaotic. Okay, can you see? There's no pattern there at all, really. Okay, so basically the brain waves are just doing what they want to do, and that's very typical of infantile spasms. We call this a hypsarrhythmic EEG. So this child is having a very typical absent seizure, okay? And you can see that he's basically going vacant, but he's having movements. You don't stop nods, okay? Now he's hyperventilating. We've asked him to blow, or the doctor who's treating him has asked him to blow, because we know that if you have absence epilepsy, hyperventilation can trigger the seizures. So we often do this in a clinic setting to try and see if the person's got absence epilepsy. We'll get them to blow on a windmill or a piece of paper. And if they basically have a vacant episode, it tells you there and then that they've probably got absence epilepsy. And with absence epilepsy, the EEG pattern is again very typical. So you can see completely different to the infantile spasm, which looked completely chaotic. You've actually got a pattern here that you can make out. And with absence epilepsy, what you get is 3 per second spike and wave activity. So you have a spike followed by a wave, and there's 3 of those complexes in every second, and it involves the whole brain, and that's why you can see it in every lead that's there. So this baby's having a tonic seizure, so basically got stiffening of the arms. And tonic seizures we don't like to see. Tonic seizures that start early again seem to suggest that you're more likely to have an epileptic encephalopathy, an epilepsy which is going to be difficult to treat potentially, but an epilepsy which is probably going to be associated with significant developmental impairment. So this is quite an exaggerated form of a myoclonic seizure, so a sudden jerk. And so much so that she's being knocked off balance when she has her myoclonic seizures. And this chap has sudden loss of tone seizures, so he has atonic seizures, so he just loses his tone and his head drops, okay? And again, atonic seizures we don't like, because again it's suggested that you're more likely to have a developmental epilepsy encephalopathy, a bad news epilepsy that's going to prove difficult to control, and is going to affect your development going forwards. And atonic seizures may be part of another syndrome called Lennox-Gastaut syndrome. So what we know is that about 1/3 of children who have infantile spasms will go on to develop another difficult type of epilepsy syndrome as they get older, and that's Lennox-Gastaut syndrome. Okay? So it's not that once you get on top of the infantile spasms, everything's great as far as the epilepsy is concerned. Far from it. A lot of these individuals will go on to develop other types of epilepsies, and a good proportion will go on to develop Lennox-Gastaut syndrome, which again is another difficult epilepsy. And with Lennox-Gastaut syndrome, you unfortunately have many seizures of different types, including the drop attacks, on a daily basis. These are the children and young people who wear the epilepsy helmets, okay, to protect themselves. And as the time goes on, that developmental gap between them and the normal peers widens, okay? And they're more prone to having status epilepticus, prolonged seizures which require rescue medication to try and get top of. And with Lennox-Gastaut syndrome, what you basically get, particularly if you get the EEG during sleep, so if you do a recording in sleep, what you'll basically see is spiked slow wave complexes, which are quite frequent, and the background electrical activity, the normal background electrical activity, is abnormal and a lot slower. The most important investigation for epilepsy or movement issues is getting a video recording. Okay, so if you are going to hospital with your child because of movement problems, the first thing that people will ask you, or not necessarily the first thing, but what you'll definitely be asked is, do you have any video recordings of these episodes? All right, and that is not just because we're trying to make your life difficult, all right, it's just because if we can see an episode, it helps us to make a clinical diagnosis about whether this is likely to be epilepsy or whether it's likely to be something else. All right. And I know that some people's seizures are so short that it's just impossible. And also, if you've got a child or a loved one having a seizure, the last thing you want to do is get your phone out to take a video recording. You know, you'll want to go to them to make sure that they're safe and that they know that someone that they know is close to them and with them. Okay, but having a video recording is extremely helpful for us. In the olden days, and this is when I was training, so that might seem a long time ago for a lot of you, but it's not that long ago. We used to, before video cameras and before mobile phones, we would often say, can you bring somebody into clinic who's seen you have a seizure? So then we'd get the description, okay? Now, as I said, that we just basically say, do you have a video recording? So we're just going to touch briefly now on treatment options. So there's lots of anti-seizure medications. Some of you may recognize some of these brands that are there. Okay. And the number of medications has increased massively in the past 20 to 30 years. Okay. It wasn't too long ago where we basically had just a handful of drugs that we always used to use. Okay, but in the past 20, 30 years, there's been a massive explosion of the various drugs that are available to us. And that's important because what we know is that although the vast majority of people with everyday epilepsy are well controlled on a single anti-seizure medication at a modest dose, there is a proportion, up to about 10 to 30% of patients whose epilepsy is more difficult to control. And therefore having different epilepsy medication options can be helpful for that group of patients to try and get some better control of their epilepsy. You'll notice CBD, all right, that's cannabinoid, okay? And when this first came out, every parent wanted it for their child, okay? Now CBD is an effective anti-seizure medication for a number of patients, okay? But it's not a sort of a magic medication that's going to stop everybody's seizures, all right? And we're allowed to prescribe it in 2 epilepsy syndromes, okay? One is called Dravet syndrome, which I haven't touched upon, but that's a focal epilepsy that starts again at around 1 or 2 years of age with prolonged seizures. Often starts off with status epilepticus occurring with infections, with fevers, and these children often will require rescue medications to try and get on top of their epilepsy. But we can also use it in Lennox-Gastaut syndrome that I have described, okay? So at the moment, we're only allowed to prescribe it for those 2 epilepsy syndromes, Dravet syndrome, or severe myoclonic epilepsy of infancy, and Lennox-Gastaut syndrome. Now, severe myoclonic epilepsy infancy, or Dravet syndrome is the other name, has a genetic diagnosis. You're looking for the SCN1A mutation, okay? So that's quite straightforward in the sense that you can do the genetic test to see if that person's got that mutation. Lennox-Gastaut syndrome, however, there is no single genetic cause for, okay? There may be an underlying genetic cause, but really that syndrome is what we call a clinical diagnosis. It's depending on what that person or that child is doing and the history, basically. So it's easier for people with difficult epilepsies who have developmental problems, seizures of many types, to sort of say that, okay, they fit quite nicely with Lennox-Gastaut syndrome, so therefore we could give them CBD. So you'll find that we are using it for the more difficult epilepsies. However, drugs don't work for everybody, okay? And drugs may actually cause more side effects which cause more problems for that individual, okay? And those side effects might be, for instance, with appetite, being too little or too much. It may be with the behavior, okay? We know that some anti-seizure medications will cause things like low mood, okay, and depression. We know that some anti-seizure medications can cause increased risk of self-harming and suicidal thoughts, etc. So it's important, and some anti-seizure medications can cause hair loss, for instance, and that can be a massive issue for some of our younger patients who basically just, want, the hair is very important, isn't it, for many people. I was going to say women, but that's not fair, because I think we men also go through these anxiety phases when the hair starts falling out. But for some men, having their hair suits them. So that's great. So ultimately, we have to think about other treatment options as opposed to just medication. And one of the treatment options is basically the ketogenic diet, okay, which is a high-fat, low-carb, low-protein diet. When we feed our bodies, we like sugar because it's actually easy to metabolize, it's easy to change into energy. Okay, so it's an easy source of that energy that we need. What we're trying to do with the ketogenic diet is tell the body that there's no sugar there, not enough sugar, so you now need to look for another energy source. And the body then will basically look for fats, okay, and will then burn the fats. And if you burn or metabolize fats, you produce a waste product called ketones. Ketones are water soluble, so they can cross the blood-brain barrier and you get high levels of ketones in the brain. And for a proportion, up to about 30 to 50% of individuals with epilepsy, if you have high ketone levels in the brain, that can actually improve your epilepsy control. So the ketogenic diet, to some extent, is mimicking starvation. Okay? So if you don't eat, you don't get those carbohydrates in, your body will ultimately start burning the fat that you've got already stored within your body. Okay? We don't actually know how it works or why it works, but it does. The problem with the traditional ketogenic diet was that it was just full of fat. It was just basically fat. So if you've got somebody who knows what they like to eat and the taste of the food that they like, being on the traditional ketogenic diet could be very difficult to maintain. All right? Unless they were being tube fed, you can just get it through the tube, and that bypasses your taste buds, etc. But now we also use a modified Atkins diet, which is a bit more liberal in protein, which basically means that you can eat things like meats or lentils or pulses, etc., which are more palatable, and therefore that suits more people to be on. Because what you can't do on this diet is suddenly go and have a Mars bar, suddenly go and have a packet of crisps, because all that will basically do is that the carbohydrates then come in, your body will switch to metabolizing the carbohydrates, and ketone levels will just drop, and that might then trigger seizures. So once you're on this diet, it's like you have to be quite rigid with it. But if it works for you, we know that if you can continue for at least a couple of years, then there's a chance that we might be able to come off it gradually, and the benefits will be maintained. Another treatment option is the vagal nerve stimulators. This is like a heart pacemaker. You know, some people with heart rhythm abnormalities have a cardiac pacemaker. This is similar, but instead of connecting it to the heart, you basically connect it to the left vagus nerve, which is one of the big nerves in your neck. And what the stimulator does is keep on firing and stimulating that nerve. And again, in about up to 50% of individuals, that can help improve seizure control. We don't know why it works, but it can sometimes help. So this is another treatment option that we have for people with epilepsy. And then the final treatment that we have is surgery. If you can find the bad bit of the brain that's causing the epilepsy, and if that sort of coincides with an MRI scan change in that area, plus the EEG abnormalities during a seizure seem to be coming from that, that'll give us more reassurance that that's the bad part of the brain. You can potentially cut it out, and this may actually be a curative way of dealing with the epilepsy. Okay, but the problem is, if you cut out a bit of the frontal lobe, as this scan is showing, you're going to be left with deficits. Okay, so it's not just a matter that you cut it out and yet everything's hunky-dory because your epilepsy is gone. The problem is, if you do something like this, you're probably going to leave that person with weakness down the opposite side. Okay, so they'll basically have a useless hand, and they'll basically have the walk with a limp because they've got a weak leg on that side. So again, it's important for us to sort of discuss what the options are. So for some people who are having daily seizures which are wiping them out for days on end, having surgery and being left with weakness may actually not be a bad thing for them, because they can get on with their life. So it's about making sure that we have the psychology input, we have the physiotherapy input, and we basically find out what the deficits are likely to be after you've had surgery, and have those discussions with the patient or the families to see whether that is something that they would be able to live with and would like to still pursue the surgery. So the last couple of minutes, we'll just talk about epilepsy mimics. So what I'm trying to say is, and I said right at the beginning, that there are some conditions which may present with movement disorders, etc., but aren't due to epilepsy. All right? And a lot of my job, and my jobs and my colleagues, is trying to determine what is likely to be epilepsy, what is not, and what is the best way forward with regards to management. So this chap is having quite jerky movements, so he's basically having a type of dystonia, okay, which is basically causing him to sort of move his arms and legs like this. These are co-appetite movements, so this is not epilepsy. This is probably due to some basal ganglia type abnormality, or maybe due to underlying cerebral palsy and brain injury, which causes these movements. This girl is having complex tics, okay, and probably has Tourette's syndrome. But these can be mistaken as being epileptic seizures. This chap has autism spectrum disorder, and he has behavioural stereotypies and hand flapping. And we often get children with autism referred to us about whether these could be epileptic seizures. Sorry, I set my own time. I'm running behind there. Right, okay, and then non-epileptic attack seizures. Okay, so we know that a lot of people have non-epileptic attacks. We used to call them pseudo-seizures or psychological seizures. So what you'll notice compared to a true epilepsy is that these movements seem to be quite violent and excessive. That seems to be a common finding with psychogenic seizures or non-epileptic attacks. Often there's severe pelvic thrusting and people are described as moving across the floor during the episodes. Okay, so if you get these sort of descriptions, then you should think about whether this could be a non-epileptic attack. And non-epileptic attacks are important to manage properly. You don't just say stop messing about, okay? Because it's likely to be a significant psychological issue. And we know things like child abuse are more common in individuals who present with non-epileptic attacks. The other thing to be wary about is that a lot of people with true epilepsy can also go on to develop non-epileptic attacks. So it could be a combination of both. And that's quite easy to understand. If you've got epilepsy, you're probably somewhat restricted in your lifestyle. You know, it affects your social integrations. Okay, there's a big stigma about having epilepsy. People might treat you differently. Okay, you might be excluded. And that can then cause undue stress, which then might manifest and cause you to have non-epileptic attacks. Because non-epileptic attacks are a type of coping mechanism for undue stress. All right? And that's why you can have a combination of both. And again, that's important for people like me to know that we shouldn't just assume that if you've got somebody who's got a diagnosis of epilepsy, if they're coming on having more episodes, that this must be because their epilepsy is worse. We have to take the history again and see whether these could actually be non-epileptic attacks alongside the true epileptic seizures. So final slide. If you're concerned about unusual movements, take a video and show them to your paediatrician or GP. Recognise that some unusual movements can actually be normal variants and may not be epilepsy. Okay? And ensure that if you're still concerned that you're seen by a paediatrician or an adult neurologist who has an expertise in epilepsy to try and get to the bottom of what might be going on. Thank you.